Thank you very much. We're going to move on to the next presenter, Jim Araby, Executive Director, UFCW Western States Council. Welcome.
Thank you, Mr. Chairman, and thank you, members of the committee, for holding this very important hearing on, the main drivers of costs of healthcare. My name is Jim Araby. I'm the Executive Director to the United Food and Commercial Workers Union. We are a union of over 160,000 members here in the state of California, primarily in grocery, but we also have workers throughout the food chain, in food processing plants, and in the agricultural industry, as well as in retail drugstores. And I want to thank you for your ongoing efforts in addressing the concerns with Sutter Hospital and in helping end their dispute with Blue Shield. Our members, and that was a very high-profile case, our members' lives were really put in crisis when they received letters from their hospital. You can imagine someone that's had a doctor for over 30 years getting a letter from Sutter Hospital saying you're going to have to change doctors. I mean, from Blue Shield, you're going to have to change doctors because we have a conflict with Sutter Hospital, and that really created a crisis in our members' lives that we would not like to see again. And we really thank the legislature for really having an impact on that settlement. But just because that has been settled doesn't mean the overall drivers of what created that crisis have been settled. And Mr. Chairman, you said at the beginning, and I think it's the most relevant to this conversation about what's driving the cost to the consumer, the patient of healthcare. And we really believe our dispute with Sutter, our trust fund's dispute with Sutter Hospital, really exemplifies some of the issues underlying costs to healthcare. And I just want to articulate a few points on that issue. On average, in Northern California, healthcare prices are about 38% higher than in Southern California. And Sutter's prices are higher than other Northern California hospitals. We have this lawsuit, our trust fund has this lawsuit, and in our lawsuit, we allege, and we believe true, that anti-competitive restrictions imposed by Sutter and its contracts with major health plans result in substantial price increases by its hospitals that would not be possible in a free and competitive market. We also believe that Sutter prices its services so that contracting with fewer than all of its providers is more expensive than contracting with all of its providers. It refuses to provide pricing options for contracting with fewer than all of its providers. And this is really, if you think about it, here in Sacramento, Sutter is a market dominator, where in other parts of the state where we have members, they are not, but they force us to have the same type of contracts they have up here. And we really believe that's a main driver of cost, one of the main drivers of cost in this healthcare plan. Ultimately, Sutter also insists on secret prices to eliminate comparison shopping and forbids health plans from offering incentives to use more cost-effective plans from competitors in the same network. So Sutter's prices are concealed from patients until after the services are rendered, meaning members cannot choose based on cost or value, and the healthcare plans cannot encourage members to be cost-sensitive in their increasing costs. The result, we believe, is that Sutter can raise its prices above its rivals without having to actually compete on price. The other piece of this that is of major concern to us, and we would hope the legislature pays particular attention to, is Sutter's requirements on pricing mean that members cannot get information on the cost of healthcare services prior to receiving treatment. They cannot make decisions based on price, and Sutter is trying to avoid a public jury trial of the UEBT, that's our trust fund, antitrust claims. And so Sutter is trying to make us agree to closed arbitration in their contracts, which we also believe doesn't allow for us having a real investigation into their anti-competitive pricing. So we believe the answer is the legislature should continue to look into Sutter's contracting practices and should request that the Attorney General investigate and take appropriate action to combat Sutter's contracting practices. And any new legislation passed in response to Sutter's actions should make it clear that the existing law already means that arbitration of healthcare antitrust claims cannot be imposed through the Health and Safety Code, Business and Professional Code 511.3, or parallel statutes and the Insurance Code and Labor Code. Thank you very much.
Thank you very much. We're going to move on to Amy Sheehan, CEO, Health Plan of San Joaquin. Welcome and good afternoon.
Thank you for inviting me to speak today. I really appreciate the opportunity to address you on this issue. Is this on?
Just push the button. There you go. You're on now.
Great. I have a PowerPoint slide. Hopefully that's working. This is just a little background on Health Plan of San Joaquin. We serve, as of last month, 285,000 members, Medi-Cal members, in 2 counties, San Joaquin and Stanislaus. As you can see, we've been in San Joaquin since 1996 when Medi-Cal health plans were formed, but we entered Stanislaus in 2013. So we haven't been in that county for very long. which is why we have 90% market share in San Joaquin, but really doing well in Stanislaus for market share, 56% market share. So about 2/3 of our membership in San Joaquin, about 1/3 in Stanislaus. But 285 as of January, and actually as of this month, we're serving about 290,000 members. So I was asked to talk about cost drivers in health plans, obviously from our perspective. This is not a comprehensive list, but a list of major cost drivers in health plans. I put an asterisk next to inpatient services and pharmaceuticals because those are the two that I want to talk about today. I'm not going to be talking about any other ones listed on this. Really, as previous speakers have said, I'm going to be focused on unit cost issues, what's driving the cost. Hospitals. Our service area is dominated by the large, either for-profit or not-for-profit integrated health system hospitals, predominantly Tenet, Sutter, and Dignity. When you're a small plan like us compared to Blue Shield, Anthem, we have virtually no leverage in being able to negotiate fair rates with these large hospitals. And as the hospitals continue to consolidate, we are getting more concerned about this. And on top of that, while we enjoy having a public hospital who we partner with in San Joaquin, a public hospital does not exist in Stanislaus. So we have a more critical problem in Stanislaus than in San Joaquin. So just to illustrate the unit cost problem, I just pulled out a little bit of information over a 6-month period of January to June 2014. So this is last fiscal year data for us. And so a Tenet hospital in Stanislaus average cost per day was $2,338. Sutter Hospital in Stanislaus, average cost per day, $2,490. Dignity Hospital in San Joaquin, average cost of $2,148. You compare that to the public hospital, who we have a very good collaborative relationship with, the average cost per day is $1,549. So you can see the major differences in inpatient cost per day from this example. So because of the market dominance in our area, if you combine these three chains, Tenet, Sutter, and Dignity, they account for 69% of all of our inpatient admissions. So I can't divert anymore. We tried, obviously, using the public hospital and the independent hospitals more, but they continue to dominate because that obviously our patients have access to various different hospitals, and these are where they get admitted. And so again, that's for January through June data. So how does this compare to the reimbursement we get from state of California? We're definitely underwater as far as these three hospitals go. So the Tenet, we are paying over the 6-month period, we paid $139K more than what we got reimbursed. And for Sutter, $403K more. Dignity, $1.76 million more than what we were reimbursed. Without the other hospitals, the other 30% of the hospitals, this would not ever work. The math itself would not work. So we obviously work on, as previous speakers have mentioned, through medical management, decreasing the number of admissions, obviously keeping it to appropriate admissions, and decreasing the length of stay. So we are doing our best on the utilization aspect, but the unit cost is we simply have no leverage in reducing unit cost. So I'm going to move on to pharmaceuticals. I know there's other speakers who are going to talk about Hep C and other high-cost drugs, but I wanted to talk about it from a more pharmaceutical global perspective. And so the thing that's actually been creeping up for quite some time, but we haven't really talked about, are the unit cost of existing brand and generic drugs. So over the last year, our health plan at San Joaquin's 25 most used brand drugs increased in unit cost by 25%. Meanwhile, generic drugs over the last 2 years increased in unit cost by 27%. And that 27% represents 9.6 million additional costs per year. So never mind the Hep C, just the existing drug costs continue to increase, again, on unit costs. We can do all we want on utilization management, but once again, the unit cost we have no control over. Second example is a supply issue. There's a generic drug called clomipramine, and that's been generic for decades. But there was a supply issue, and so the generic manufacturer went down to one manufacturer producing this drug. So what do? They increased the price from 28 cents a tablet to $8.21 a tablet when they had market advantage. So what do we do about that? Nothing. Patients need to continue to receive this drug, so we continue to provide it. Then there are rare diseases for which orphan drugs exist. And one example of a member that joined us in last fiscal year came with a genetic condition, nephropathic cystinosis, I hope I'm pronouncing that correctly, required a drug called Procysbi, which is $48,000 a month. You get one or two of these rare diseases joining, you're underwater immediately. So Mary Cantwell mentioned it a few minutes ago, but in November 2013, DHCS had to mandate the use of Makena, which is a brand name FDA-approved drug. At that time, the routine practice is using compound formulation for the same drug. So that increased our unit cost from $120 a month to $3,500 a month. Then again, hepatitis C, I'm sure you're going to be going over that in more in detail. So obviously, everyone's been talking about the new therapies on the market. And for us at the health plan, every patient that's on it, we're spending average of $1,000 a day or $60K to $200K per treatment. And it's especially, I think, critical to the Medi-Cal plans because while the commercial population has a prevalence of 0.07% hepatitis C, in Medicaid population, it's double that. 0.87% of Medicaid population is infected with hepatitis C. And then you add to that the prison population, when they leave the prison system, they become Medi-Cal eligible and join us, 30% of them have hepatitis C. So, and recently with all of the changes in the Affordable Care Act, we are getting more of the prison population join us month after month. And so this is really, the hepatitis C drugs disproportionately affects Medi-Cal plans than commercial plans. Then finally for us, before all the hepatitis C hit a little over a year ago, we were really focused on and concerned about the cancer treatment. For us, 92 members, which is only 0.07% of our members, accounted for 4.1% of our total drug spend, which equated to $2.12 million. 92 members using 2.12 million per year, and this is just outpatient cancer drugs only. We're not counting about inpatient cancer treatment. So this equates to $7,000 a month or $23,000 a year, and we have been tracking all the new cancer treatments hitting the market, and those are listed there for you. And as you can see, the cost of these treatments are going to be unsustainable. And then one problem that was recently taken care of was the hemophilia drug. There's another Medi-Cal plan who had 5 patients that had hemophilia with a cost of $32K per month for each of those patients. Luckily, the HCS were able to carve that out of our risk-bearing capitation, so we are no longer bearing that cost, but it was after years of bearing that cost and with not enough reimbursement. So that is my presentation. Thank you.
Thank you very much. The next presenter is going to be Doug McKeever, Chief Health Policy Research Division, CalPERS.
Good afternoon.
And welcome.
Good afternoon, Mr. Chair, members of the committee, and my apologies to the members to my left who I'm not going to be able to see very well in speaking today. We want to thank you for the opportunity to share our perspectives on making healthcare more affordable. I'm Doug McKeever, Chief Health Policy Research Division at CalPERS, and in the time I have, I'm going to provide just a brief overview of the following that impact CalPERS and its members. One is just a context-setting perspective on who CalPERS is and who we serve. Secondly, what are those major cost drivers for CalPERS? And I think it's always instructive to be able to provide some solutions to those issues. So we're going to offer you what it is that CalPERS has been doing and continues to do to address the affordability issue. So for context purposes, CalPERS covers 1.4 million members throughout California. That includes the state of California, state employees, as well as over 1,200 contracting agencies, cities, counties, schools, special districts. We contract currently with 6 health plans that provide HMO coverage throughout the state in various geographical locations. I want to point out Kaiser Permanente is one of those and has the lion's share of our membership at over 500,000 members. We also contract with one provider, Anthem, who is our third-party administrator, who administers our 3 self-funded products. Our total spend for 2015 is $8 billion. Not an insignificant amount of money that we're putting into the healthcare system. To put that into context, on a daily basis, we're almost spending $22 million on a day, every day of the year. So for us, it's an extremely important issue to deal with the affordability of healthcare, but we also don't want to lose sight of the quality component and the access component as well. Our major cost drivers are not much different than others. So I'm going to cover for you what some of those are. Some have already been mentioned, so it'll just be a reiteration of some of those things that have been spoken to already. For example, facility costs, primarily at the hospital level. Obviously, that is a major cost driver for CalPERS, has been, and we continue it, and we believe that it will continue to be as well. For obvious reasons, emergency department, emergencies that take place, car accidents, folks have to use the hospital, so there are inpatient and outpatient opportunities that folks have to go to the hospital for, many of which have high cost value to them, especially when you come to issues like neonates and cancer, which require an aggressive amount of treatment in an inpatient setting, and certainly that brings with it a cost level as well. And anything that has to do with end-of-life care services is a high cost driver for us. It was mentioned earlier, chronic conditions, and CalPERS is no different when it comes to chronic conditions and our population. Our current statistics show that 25% of our members account for 50% of our healthcare cost spend. And these are in the conditions such like diabetes, obesity, high blood pressure, and heart disease. Pharmacy is a pain point for CalPERS, and I think you're going to hear that echoed throughout the afternoon, especially in the area of specialty drugs. In October of 2014, we reported to our Board of Administration that in 2013, our total pharmacy spend was $1.5 billion. Of that, 2% of our members accounted for 20% of that total spend in the specialty drug arena. That's for 2013. For 2014, we're expecting that to go up for obvious reasons, one of which happens to be the Hep C drug that's already been referred to. Types of conditions covered by these drugs and which are in the top 10 drugs prescribed by our program include things like rheumatoid arthritis, multiple sclerosis, cancer, and the aforementioned Hep C. We also deal with regional challenges, rural, urban, and in many cases, those geographical areas where competition is not even existent. Santa Barbara County is an example. There are also some variances in cost between the North and South that was mentioned earlier, where their costs in the South seem to be much lower than those in the North. So what is CalPERS doing to address some of these trends that we've seen historically and continue to see? One, in 2014, we offered competition by adding additional health carriers to our plans. Prior to 2014, we only had 2, Kaiser and Blue Shield. As I mentioned earlier, we now have 6 providing our HMO services throughout the state. We've implemented integrated healthcare programs, which are like ACOs for Medicare, in which they have risk-sharing contractual arrangements between the hospitals and the providers and the health plans, which gives us a line of sight into the services that they are providing, as well as the contractual relationships between those partners so that we can see how those dollars are being spent. We have also found value in promoting narrow networks, but in doing so, we want to make sure that there's a balance between cost and quality. We strongly endorse and encourage the adoption of innovative provider relationships, like the one that was just announced not too long ago by Anthem, that is called Vivity. It's in Los Angeles and Orange counties, and it's innovative because it's bringing competitors in the marketplace down in those 2 counties together and collaborating in a partnership, which is moving away from fee-for-service more into the capitated arrangements. You've got providers like Cedars-Sinai and UCLA Medical Center now joining in partnership rather than competing with the members who are part of that Vivity program. And then lastly, on the pharmacy side, We currently conduct annual market checks to ensure appropriate pricing. We vigorously support pathways for biosimilars and strongly advocate and expect strong formulary management and medical oversight, especially when it comes to specialty drugs. There needs to be discipline in the use of these new drugs. It hasn't been mentioned yet, but as an example, not everybody who has Hep C needs Sovaldi. I think it is worth noting that specialty drugs play an important part in the quality of life for many of our members. This is very important to CalPERS, and it should be considered in the discussion of these high-cost drugs. Again, thank you for the opportunity to provide our perspectives, and we'll be happy to answer any questions at that appropriate time.
Okay, our final panelist for this section is Dr. Samir Aswar, Associate Executive Director of Pharmacy, Adult and Family Medicine, Kaiser Permanente. You can just move the, you want?
I was just going to stand so I'm
Okay.
not being rude to the rest of the committee.
Welcome, good afternoon.
Thank you for inviting me. I'm Samir Aswar. I'm an adult primary care physician in Campbell, California. That's where I see my patients. And my other job is the Associate Executive Director for the Permanente Medical Group in Kaiser Permanente, and a couple of my areas of oversight are pharmacy and adult primary care. I would like to thank Senator Hernandez and the committee for holding this hearing. We understand that the main goal of this hearing is to hear what the most compelling cost drivers that concern our organization are. While there are many serious and complex healthcare issues that have been brought up, I can assure you that nothing is of more concern to Kaiser Permanente than how the pharmaceutical industry has chosen to price non-orphan specialty drugs. Let me use the PowerPoint. You've already heard that there has been an upward trend in specialty drug pricing, and they are now a growing proportion of our pharmacy spending. And this is really concerning. If you looked at pharmaceutical prices in 2012, specialty drug prices actually increased 19%, without which actually the overall pharmaceutical spending growth would have decreased. And double-digit growth has been seen in 2013 and 14, and this trend continues to increase. As you can see, in 2013, specialty drugs only accounted for 1% of the prescriptions that were written. However, they make up 25% of the total drug spending. And this is only going to quadruple. Specialty drug spending was $87.1 billion in 2012, which is now going to go up to $401 billion in 2020. So actually, if you look at that next graphic, what it shows you is specialty drug costs by 2020 will end up being 50% of all of the pharmaceutical costs over this decade. And that is extremely concerning to us. So what we are seeing now is that more and more high-priced specialty drugs are now being approved, which are for non-orphan diseases. So that means these are not for rare diseases that affect just a few hundred or a few thousand people. These are diseases that are pretty common, and we have drugs that will be able to treat people, yet they're kind of expensive and out of reach. To add to this, there really is a true lack of competition. I'll talk about that a little bit. And the case for this is really Gilead's two drugs that are out, which are Sovaldi and Harvoni. These are both drugs for hepatitis C, which is a contagious viral infection that affects between 3 to 5 million people in the United States. And here are the two drugs, Sovaldi, which is at about $1,000 a pill. And as you can see, it has a moderate to high cure rate. And when they combine Sovaldi with another drug, that is $1,125 a pill, which has a very high cure rate. And as you may know, Gilead actually acquired the rights to this drug from Pharmasset, and the rights for Sovaldi were $11 billion. If you looked at Gilead's books, which closed recently, you will notice that they actually generated $12 billion in revenue in the first year alone for the drugs Sovaldi and Harvoni. So no one is actually questioning the clinical efficacy of these drugs. These are really good drugs. These are actually significant advancements in treatments for our patients. But hepatitis C is really not a rare disease. This high price tag actually hinders the widespread use and access of this medication, which can actually eradicate a very serious public health disease. The pricing actually stands in the way of patients actually getting benefits from this medication. If this drug was actually used to treat all 3 million patients that have hepatitis C in the United States, the list price would be about $300 billion. And this is actually the total amount of money we spent on every other drug in this country. So actually using this medication to treat hep C would double the cost of treatment of every other condition in the US. And it's quite interesting to see what the pricing for this drug has been in other countries. If you take a look at Egypt, the entire cost for the whole treatment is $900, which is actually less than the price of one single pill here in the United States. And in India, it's $2,000. In some of the European countries, it's less. And again, in the United States, you see the most highest pricing for this particular drug. And if you look at what some of our professional journals are talking about, people understand that we have limited resources in this country. And what some of the professional guidelines are suggesting is that you actually take a look at what available resources you have and actually prioritize how you would treat patients. And this is a really odd situation to put a physician or clinician in. As both Drs. Hernandez and Pan would realize, this would be a tough conversation to have with your patient. You might have to say to them, you know, you're not really sick enough to get this medication at this point. If you look at the Liver Society guidelines, they actually tell you to prioritize for people who have really severe cirrhosis. Yet, when patients have just the early part of hepatitis C, they can get this drug and be cured 95 to 99% of the time. Yet we're going to tell them, why don't you wait a little bit till you're sicker, then you can maybe have this medication. And as a clinician, I find this a very difficult conversation to really have with my patient. So Sovaldi is not the only issue. It's really the canary in the pipeline. I think several speakers have brought up the cancer medications. As you can see, 58 cancer drugs were approved by the FDA between 1995 and 2013. And each year, they have been increasing the price of these drugs by 10%. And again, as it was mentioned by a different speaker, the FDA approved 12 cancer drugs in 2012, and 11 of them were priced over $100,000 per year. And this is absolutely outrageous. Actually, if you take a look at Gleevec, which was approved quite a while back in 2001, it was actually marketed at $30,000 a year. The price for this drug this year is $92,000. I find it hard to believe that over the last 14 years, the production costs of this drug have tripled or have gone up by $60,000. But yet, this is what the pharmaceutical industry is currently doing. So our pharmaceutical industry colleagues will say something like, well, but Sovaldi is actually worth the price, right? And if you take a look at some of the comments that they've put out, they say, well, it's certainly cheaper than getting a liver transplant. And if you take a look at how many people actually end up with a liver transplant, it's only 1% of our patients who have hepatitis C will get a liver transplant, which costs $580,000. So actually using that comparison to treat people who just have plain hepatitis C really does not make sense. So it's really not a value to the healthcare system. It is really a return to the manufacturer. So I would actually suggest follow the money. They might also say, but the market's actually working. You know, there have been lots of other drugs, and AbbVie just came out with another drug, and surely market competition will take care of this. If you take a look at the pricing of AbbVie's drug, it's only less than 1% difference than the Sovaldi drug. So I would actually point out to you that the competition is not working. And this is not restricted to just the hepatitis C drugs. If you actually look at lots of these commercials you'll see on TV on rheumatoid arthritis drugs, and you'll see commercials for multiple sclerosis drugs and drugs for psoriasis. Sometimes there's 5 or 6 or 7 different medications, yet competition has not brought down the cost of these drugs. So what is the answer? There's a lot of federal law, there's a lot of complex licensing and patents that are involved here. So there really is not a very easy policy approach that can happen here at the state level. But we need to have forums like this to have a robust public dialogue about sustainable drug pricing and to show how drug prices actually impact affordability. We actually have to ask ourselves whether the prices reflect the value of these medications and what are we actually willing to sacrifice to pay for these prices. You recently saw the article in the Sacramento Bee. The governor put in a few $100 million in the budget just for hepatitis C, which is more than what they have done for our national parks or problems with our water system. So I think the drug makers simply need to do the right thing by pricing their products appropriately and fairly without bankrupting the system. I think we have a looming crisis ahead, and the status quo is unacceptable. And I think the steps that this committee is taking are really a good step in that direction.